Right. So let's just continue from where we stopped last time. There are a few best response MCQs in the previous paper, which we'll come back to as soon as we finish this one. Hi. Okay, so today let's talk about diabetes. The last day we did it, we talked about the adrenal gland and the MCQs related to that. Right. So diabetes, as you know, is a very common disorder. We've talked a lot about it during the long case discussions, right? And essentially, there are the classification of diabetes. You have two main types, type 1 and type 2. And there are a list of other specific types of diabetes as well, which includes genetic syndromes and drug-induced, etc., etc. Harry? Right. Okay. Now, this MCQ is essentially comparing type 1 diabetes with type 2 diabetes, right? And in the next slide, I have sort of given you a table comparing the two with regard to MCQ points, right? Now, as you know, type 1 diabetes, the age of incidence is much lower than type 2. And we have these patients presenting in childhood or adolescence. The important thing to remember is type 1 diabetes is an autoimmune syndrome and is associated with HLA-DR3 and HLA-DR4. So there is a genetic predisposition, right? And there is a clear autoimmune pathogenesis to the disorder, right? And if you measure antibodies, autoantibodies, there are a range of autoantibodies in these patients, like anti-GAD antibody or anti-insulin antibody or anti-islet cell antibodies. And there are lots of other antibodies, autoantibodies, right? Compared to this type 2 diabetes, the fundamental pathophysiological problem there is insulin resistance, right? So that is the main problem, and there is no clear HLA association, right? And insulin resistance is the key problem. So question number 3 then, type 1 diabetes is associated with HLA-DR3 and HLA-DR4 positivity is true, right? And because type 1 diabetes is autoimmune, you see in type 1 diabetes various antibodies, right? But in type 2, there is no such thing. So the second thing is wrong, right? Right? So the autoantibodies are all seen in the type 1 diabetes phenotype and not the type 2 diabetes phenotype, right? Now, even though we talk about a genetic predisposition for type 1 diabetes, there is also actually a stronger genetic predisposition for type 2, right? And if you look at family history and the probability of developing type 2 diabetes, there is a very strong genetic predisposition, right? It's not HLA mediated, but there is a clear genetic predisposition for type 2 diabetes as well, probably even stronger than type 1. Right? There is a stronger genetic susceptibility or a genetic predisposition for type 2 diabetes. So, now, as you know, typically type 1 diabetes patients, they present in childhood or adolescence. And the key thing to remember is they usually present with the classical symptoms of diabetes, the osmolar symptoms that all of you are familiar with, right? And they usually have weight loss as part of their presentation. So they present with weight loss, right? But type 2 diabetes patients, they present with weight gain. And as you know, there is a strong relationship with insulin resistance in these people. So type 2 diabetes associated with insulin resistance is true. Type 1 diabetes presents with weight gain, these usually presents with weight loss and also the classical hyperosmolar symptoms of hyperglycemia like polyuria and polydipsia. So that is question 3, comparing the main two types of diabetes. But remember, there are other types of diabetes as well, which are described in the literature. Any questions about that?
Excuse me, sir. May are types of diabetes එකේ ලාඩෙන්නේ type 1 එකට නේද? නැත්නම් other specific?
Other types වලට තමයි ඒක ගන්නෙ. Yeah.
Okay, thank you.
Okay. Any other questions? Right. Chamatkala, I'll answer your question. Just give me a second. Hari, ek abhi passe kata karu. Right. Okay. Right. Now, this next question focuses on the diagnosis for diabetes. Right. Diagnosis. Now, this is the standard diagnostic criteria which all of you are familiar with for diabetes. Right. So, there are 4 types of tests that you can use to diagnose diabetes. Right. So, one is the HbA1c, or you can use the fasting blood glucose or the 2-hour glucose value. Right? So 2-hour glucose is the OGTT test, where we use 75 grams of anhydrous glucose and measure the glucose after 2 hours. So that is this classical OGTT that we talk about. Now you can also use the random glucose, right, for diabetes diagnosis, but remember, when you are using the random glucose, the patient has to have the classical hyperglycemic symptoms, right? You can't use the random glucose in isolation, right? You have to have the classical hyperglycemic symptoms, or the patient has to present in a hyperglycemic emergency, like diabetic ketoacidosis or hyperglycemic hyposmolar state. So they should present in the crisis, or they should have the classical symptoms of hyperglycemia for you to use the random glucose as a diagnostic test, right? So this is the standard diagnostic test, and we usually recommend a repeat of these tests for confirmation, right? That's what the American Diabetes Association talks about here, right? Okay, right. So OGTT is essential for diagnosis කියන එක වැරදි, right? So OGTT is essential for diagnosis කියන එක වැරදි. That is wrong, right? තප්පර දෙන්න. Sorry. Right. Okay. So you can use other diagnostic tests also, right? It's not only the OGTT that we use. Then the next MCQ is HbA1c reflects glycemic control. So Shamalka, yes, usually if the HbA1c is high, we usually repeat it. If the patient is asymptomatic, we usually repeat it. Hari? Nattam we start treatment, but actually the ADA recommends that you should repeat all positive tests because you can have laboratory errors. But in a practical situation, if the patient is symptomatic and one of these tests is positive, we usually start treating them for diabetes. Right. Now the HbA1c has a importance not only in the diagnosis but also in the monitoring of a patient with diabetes for their glycemic control, right? And HbA1c can reflect the glycemic control over the last 2 to 3 months duration, right? So it doesn't give a 6-month cover. So last 2 to 3 months wage, you can get an idea of how the glycemic control is with the HbA1c level, right? That is the role of the HbA1c. Okay. Now remember that the HbA1c measures glycosylated hemoglobin, right? So any condition that causes reduction of lifespan of the red cell can cause a falsely low HbA1c because the red cell lifespan is low, right? And the red cell hemoglobin is broken down quicker, right? So this is classically seen in people with hemolytic anemias, hemoglobinopathies, right? Where their red cell lifespan is low. So the hemoglobin glycosylation, the lifespan is low or the duration is low. So you get a falsely lower HbA1c in people with hemoglobinopathies, right? So that is, you have to interpret these tests with caution when there is some disorder which is causing a low red cell lifespan. So that is the important message. Hari. Okay. Now, apart from these diagnostic tests that we talk about, right, you can also, for type 1 diabetes, you can also measure their autoantibody levels, right, which might assist in establishing that it's an autoimmune type diabetes, right. C-peptide, what happens to C-peptide, as you know, C-peptide levels correlate with the insulin levels, right? Because we don't usually measure insulin levels, we can measure C-peptide levels, which correspond with the insulin levels, right? Because C-peptide is a part that breaks off the insulin molecule when it is initially formed. So in patients with type 1 diabetes, because there is no insulin, right, the C-peptide levels are low. But in type 2 diabetes, especially in the early stages and in most of the situations, because of the insulin resistance, actually insulin production is increased, right? So you have insulin production being increased in the early stages, right? Because of the insulin resistance, your pancreas is trying very hard to produce some insulin to counteract that resistance, right? To overcome that resistance, right? To overcome that resistance. So because of this, remember that in type 2 diabetes, in the initial stages, you can have a higher C-peptide level, right? Because the insulin levels can be slightly elevated. Okay. Right. So random blood glucose cannot be used in the diagnosis of diabetes kenika. I told you that in the specific situation where you have a random blood glucose of more than 200, plus the patient has classical hyperglycemic symptoms or they present with a crisis, you can still diagnose diabetes. So make a Bharati. Right. Okay. Right. So Kanishka, the HbA1c can be falsely high in rare situations. It's mostly falsely low that is important for us. So that's why the red cell lifespan comes into play, right? Anything that increases red cell lifespan can theoretically cause high HbA1c, but more the important thing is the low HbA1c, falsely low because of low red cell lifespan. Right. Now, when we were doing the long case, I took you through this management algorithm for diabetes. So I'll just remind elements of it as we go on in the MCQs. Hari. Now remember that we discussed this, that when you're managing type 2 diabetes, right, metformin is the first line drug, right? There is no doubt about it. There is no question about it. All the guidelines around the world agree with it, right? So that you should start off your treatment with metformin, right? And metformin is excellent at reducing the peripheral resistance, right? Reducing the peripheral resistance. Right. So the previous MCQ, the question here is that C-peptide levels are usually low in patients with type 2 diabetes කියලා තමයි TN statement එක. So they're usually high. In the very end stages, it can go down. But most of the time, if you would measure, we don't routinely measure this, but C-peptide levels are elevated in type 2 diabetes most of the time. That's usually නිසා තමයි එක එහෙම කිව්වේ. Right. So metformin is first line therapy that is clear cut. There is no question about it. And it is excellent at reducing the insulin resistance in type 2 diabetes. Right. There are very, very few contraindications for metformin. Very, very few. Right. Probably the only important one is when you have chronic kidney disease or acute kidney injury for that matter, where your GFR drops less than 30. Right. So that is probably the main contraindication for metformin. We also tend to suspend it when they have acute illness. Acute illness is acute organ failures like acute heart failure or decompensated liver disease. Right? But probably the key contraindication for metformin is your chronic kidney disease with a GFR of less than 30. So it is not contraindicated in all patients with CKD, specifically when the GFR is less than 30. So මෙතන all කියලා තියෙන නිසා වැරදි. Not all patients, right? Only in people where the GFR is less than 30. Okay? Metformin is known to precipitate lactic acidosis. So the reason why we don't use it in renal failure patients when the GFR is less than 30 is in that subset, when you give them metformin, they have a higher risk of developing lactic acidosis, right? So that is the reason why we do not give metformin in that situation. So metformin is known to precipitate lactic acidosis is true, right? Now, beyond metformin, what other second line drugs do we use? So in Sri Lanka, because we don't have access to some of the newer diabetes medications, for us, sulfonylureas are second line therapy, right? Sulfonylureas are second line therapy. And sulfonylureas are very good at lowering blood sugar. Right? They have a very potent, very strong hypoglycemic effect. Right? It's so strong that you need to be very, very careful in elderly people. Very, very careful in elderly people because it can cause very profound hypoglycemia. And in elderly people, we usually prefer tolbutamide, the short-acting preparations, because you can reverse them very quickly, right? Long-acting preparations like glibenclamide can cause very severe hypoglycemia, which is almost impossible to reverse also, right? Because treat karanna thari amaru, right? Causes a sustained, prolonged hypoglycemia, which is very difficult to treat. Right. Another thing that I talked to you about in the long case is that when you give sulfonylureas, it stresses the pancreas out, right? Causing pancreatic beta cell exhaustion and failure, right? So that is another drawback of sulfonylurea. Matakani sort of stresses the beta cell to produce insulin so that it can sort of cause beta cell exhaustion and beta cell failure, right? So that is part of the problem. Hari. Okay. So sulfonylureas are good first line, second line therapies for us because we don't have access to some of the newer medications. Right. Another second line therapy that we commonly use in Sri Lanka is the thiazolidine-dione group or pioglitazone. Right. The problem with pioglitazone and the other members of that group is that they can cause fluid retention. Right. They cause fluid retention. So say they should be avoided in patients with heart failure, renal failure, right? Because it can aggravate these conditions, right? Because it causes fluid overload, right? So pioglitazone should be avoided in patients with heart failure is true. Another MCQ you can get is another side effect of using pioglitazone for a prolonged period of time would be that they can develop osteoporosis, right? So long-term use of pioglitazone can be associated with the risk of osteoporosis. Right, so that is that problem. Okay. Hari, any questions about that? Question number 5, Vale? So what are the other oral hypoglycemic drugs that can be used in CKD? So CKD end stage, Vale, sulfonylureas are the most common drugs we use. The other one is insulin. Right, insulin. So sulfonylureas or insulin are the drugs that we can use. Right, most of the other drugs, when the GFR is less than 30, are contraindicated. Right, and pioglitazone, because it causes fluid overload, is also contraindicated. So commonly, you would see patients with renal failure on sulfonylureas and or insulin. Right. Right. A few more MCQs on. Tanuja, you want to ask a question?
Yes, sir. What about SGLT2?
SGLT2 inhibitors again, when the GFR drops below 30, some 15 will adunama navattanna one. You can't give right at the end. Some of the SGLT2 inhibitors also become contraindicated.
Okay.
Yeah. Tisura.
So this glycoside is contraindicated in severe renal impairment.
Glycoside contraindicated? No. So sulfonylureas are not contraindicated, but you have to be careful with them. That is, it's cautioned because of the risk of hypoglycemia. Right? And patients with CKD are more prone to get hypoglycemia. So they are not contraindicated, but caution. But we use sulfalmitamide, gliclazide in CKD, but you have to be careful that you don't overdo it. Yeah.
Right. So even in end-stage parts.
Yeah. Not contraindicated. Caution would be a better statement there. Yeah.
Right. Thank you.
Okay. Hi. Hari. Okay. Now, the next question is also on these diabetic medications. So let's talk about that. So sulfonylureas stimulate that the mechanism of action is correct, right? That's fine. Now, what are these other newer drugs, right? What are these other newer drugs in diabetes management, all right? Now, over the last few years, SGLT2 inhibitors have come up in a big way in type 2 diabetes management, right? And clinical trials have shown, right? Clinical trials have shown that over a period of time, when you use SGLT2 inhibitors, they have a cardiovascular mortality benefit, right? So they have a cardiovascular mortality benefit, SGLT2 inhibitors. In addition, when we are talking about heart failure, we've also mentioned that SGLT2 inhibitors have mortality benefit in heart failure as well, right? So over the sort of years that people have done clinical trials, these are the key findings on SGLT2 inhibitors, that they have a cardiovascular mortality benefit and they have a mortality benefit in patients with heart failure as well. And another additional advantage probably is they are weight neutral, right? They don't cause weight gain. They don't cause weight gain. Like for example, sulfonylureas can cause weight gain, right? So there are various advantages of using SGLT2 inhibitors. So current guidelines would suggest, right, that if they have heart failure, if they have cardiovascular mortality problems, cardiovascular risk, use SGLT2 inhibitors early on in the management. One last thing about SGLT2 inhibitor benefits is that people have also found now that it reduces the progression of diabetic nephropathy, right? It reduces the progression of diabetic nephropathy. So in early stage diabetic nephropathy, right, heart failure, patients who have cardiovascular morbidity, SGLT2 inhibitors have wide-ranging benefits. So they have sort of elevated their status a little bit. Now, however, you have to understand that SGLT2 inhibitors can cause serious side effects, right? Common side effects are they increase the risk of genitourinary infections. That is very clear, very clear. And in certain situations, they have been shown to cause Fournier's gangrene, which you might have seen in surgery and vascular surgery, right? So genital necrosis, very severe condition. So because that is a common problem. So genital infections, genital candidiasis, UTI, that's very common because there's lots of glucose passing out in the urine when you use these drugs. So that is a problem, right? So use of SGLT2 inhibitors have increases the risk of genital infections and reduced progression of diabetic nephropathy are true statements in this MCQ. Right. Tanuja.
Sir, SGLT2 හින්දා මේ weight reduction එකක් එන්නේ නැද්ද glucose pass වෙන හින්දා?
ලොකුවට එන්නේ නැහැ. It's mostly weight neutral. You can argue, say it causes a bit of weight loss, but not as much as something like metformin, for example. Hari? Right. Tisori, is that a hand raise before or something now?
Sorry, sir, that is before.
Hari. Hiran, insulin. So Hiran, your point is right. Partly why? Because patient. So if you take the metabolism of insulin, insulin is metabolized and passed in the urine, right? And this is why in end-stage renal failure, if you measure their insulin level, slightly higher, right? Because they are retaining a little bit of insulin. And this is possibly why that they are at a higher risk of hypoglycemia, right? So because they have a slightly higher circulating insulin level. Right. Another drug that has come up over the last few years is the GLP agonists, right? GLP agonists. Again, like SGLT2 inhibitors, this GLP-1 agonists have been shown in clinical trials over a period of time to have cardiovascular mortality benefits, right? That is one advantage of these drugs. Cardiovascular mortality benefit එකක් තියෙනවා, right? They also can cause weight loss because GLP-1 is an appetite suppressant. We sometimes use it in obese patients as well, right? So weight loss, appetite suppression, and also it is good for cardiovascular risk protection. So the second statement is true. Another benefit potentially of these drugs is that they are injectables and can be used as an alternate or a bridge to insulin. So in some parts of the world where these drugs are freely available, unlike Sri Lanka, we sometimes use this as a bridge to insulin, right? So once a week injection is better than getting insulin 3 times a day. So sometimes it helps as a bridge to insulin, right? So GLP-1, these are the benefits of GLP-1 agonists that you need to know, right? So there's a cardiovascular benefit. They have weight loss, right? Because it is an appetite suppressant molecule. And it also is a good bridge to insulin, right? Therapy as well. Okay, so that is the story about GLP-1 agonists. Now, there is another drug in that group where you still get elevation of GLP-1, and that is by inhibition of DPP-4, which is the enzyme that breaks down GLP-1, right? Sitagliptin. That is available in Sri Lanka. It doesn't have the same benefits as GLP-1, I have to say, in clinical trials, but it is available in Sri Lanka, right? Okay. Now, Now, the last MCQ statement here is on the glycemic target. Now, මේකත් මම ඔයගොල්ලෝ long case එකේ කියලා දීපු point එකක් that the ACCORD trial, that is the trial that shows this, right? According to the, so Buddhini, what I said was sitagliptin කියන්නේ DPP4 blocker එකක්, it's enzyme antagonist. It increases GLP-1 because the GLP-1 is broken down by DPP4. It doesn't have the same sort of mortality benefits as the GLP-1 agonist, but they are similar in certain situations and they're available in Sri Lanka. Right. Now, talking about glycemic targets, right? Glycemic targets. What you need to know about this is it is based on the ACCORD trial that we now recommend glycemic targets in diabetes, right? And I told you this. It has to be individualized, so it is patient-based, right? You can't just go and give a blanket glycemic target to everybody. So it is always individualized. So I told you that patients who are elderly have multiple comorbidities. So these people are elderly. They have multiple comorbidities, right? They have organ failures like heart failure, renal failure, right? And low life expectancy. So they are very poor off. They are elderly. They have lots of comorbidities. They have poor life expectancy. These sort of patients, right? You go for a looser target, say sometimes 8, HbA1c of 8, right? Whereas younger patients, you would go for a very strict target around 6, right? Or less, right? Sometimes. So they are because this is based on evidence from the ACCORD trial, right? ACCORD trial that you can't give a blanket HbA1c target to everybody. Elderly people who have more comorbidities, you have to go for a looser target because if you try to control their blood sugars very strictly, they can die. And that's what that trial showed, right? If you try to control their blood sugars very, very stringently or very tightly, these people die, right? So that is why we don't do that. So a glycemic target of 6, less than 6 recommended for all patients, that is only for younger patients who have been recently diagnosed and don't have any major problems or comorbidities. And these are based on the ACCORD trial. Shamal Kadana, GLP-1 agonist instituted reduction in blood pressure, not directly but indirectly, yes, because it improves the metabolic profile. And SGLT2 inhibitors cause a bit of water excretion as well. So potentially yes, but not a direct action එකක් නෑ. Direct action එකක් නෑ. Once the metabolic syndrome improves, the blood pressure can improve as well. Right. Okay. Right. Now the next question is about, yes, insulin. Right. And මේකත් අපි කතා කරා, when you're starting insulin, right? Sachin, you have to ask a question?
No, sir, missed it.
Right. Now, obviously, all type 1 diabetes patients will need insulin, right? But actually, they trialed SGLT2 inhibitors in type 1 diabetes because there is no problem there, right? It just excretes the glucose. It wasn't very successful. අනේ මට එක point එකක් අමතකුණා. SGLT2 inhibitor, another dangerous side effect is, I told this is a long case, is euglycemic ketosis, right? Can cause ketoacidosis without changes in blood sugar. Right, that's called euglycemic ketosis. Right. So type 1 diabetes, you have to put on insulin. People have done trials where they give SGLT2 inhibitors also, but not very successful. So insulin is a mainstay of therapy. Type 2 diabetes, when do you start insulin? Again, we discussed this in the long case. Type 2 diabetes, you start insulin based on several indications. Indication number 1 is when there is failure of your oral medication. Right? There is failure of maybe 2 or sometimes 3 oral drugs. Right. Another indication for starting insulin in type 2 patients is, say if somebody presents with a hyperglycemic emergency and you want to control the blood sugar very quickly, right? And keep it under control for a few months, right? And there is a benefit in doing that, right? There is a benefit in doing that. So initial good control, there is a benefit in the long term of doing that, right? That's called the legacy effect. Legacy effect, right? So if you have a initial good control, there is a good outcome for that patient. So if somebody presents with a diabetic emergency or very, very high blood sugar, what we commonly do is we give them insulin for a short period of time, maybe a few months, to get the sugar under control and then gradually take it off, right? So these are your indications for insulin in type 2. Either they have to have failure of several hypoglycemic agents, or they have to come with a very high blood sugar or hyperglycemic emergency, and there you would give insulin for a short period of time to control the blood sugar, right? Initial control of blood sugar, right? That is important. Right. Right. And remember that when you're giving somebody insulin, you're mimicking their endogenous insulin pattern, right? So you're mimicking their endogenous insulin pattern. So it is essential to give them a long-acting cover. That is the most important thing that you're going to do. A long-acting cover, right? So things like glargine, detamir, right? These are all drugs that give you a long-acting cover over, say, 20 hours, 24 hours. Some of them last for that long. And once you have given this basal cover, then you can supplement the mealtime insulin with more short-acting preparation. So the basic principle is that where you give them a long-acting cover and also you supplement them with a shorter-acting cover, right, with mealtimes. මම මේ ස්ලයිඩ් එකේ ඔයගොල්ලන්ට වැදගත් දෙයක් කියන්න මේ සමහරට ඔය කාලවල එහෙම MCQ වලට අහනවා අපි, right? So when does the soluble insulin start working? When does it peak? That sort of thing we can ask you. So I have given that detail in this slide, right? So Naveen, is there a cutoff value to start insulin? So usually the guidelines suggest if the entry HbA1c is more than 9 or 10, somehow depend on the guideline, to start insulin for a short period of time to get things under control, right? But that's a bit of a detail that I don't think you need to worry about, right? And sometimes when somebody with diabetes is ill, right, you will give them soluble insulin for a shorter period of time as well. So things like MI, sepsis, right? You will give them a shorter period of soluble insulin in acute illness, right? But purely for obesity poor compliance with hypoglycemic drugs, microalbuminuria, you don't give them insulin for any of that. Right? This is wrong. All right. Okay. Any questions up to now?
Sir, by soluble insulin, you mean the rapid acting form?
Acute, soluble insulin, acute illness ekakadi, you need to give them soluble insulin because that is you can titrate it very nicely and it has a rapid action. Yeah.
Right, sir. Okay.
Right. Right. Okay. Right. Now this slide shows you the complications of type 2 diabetes. Right. Complications of type 2 diabetes. So as you can see, there are few important points in this slide. Right. One is that development of macrovascular complications comes a bit earlier than microvascular complications. Right. Okay. Usually, say in type 2 diabetes, from the diagnosis, yeah. So 2 years, 3 years, you can, or sometimes before the diagnosis, so this is the diagnosis here, right? So sometimes before the diagnosis also you can have macrovascular complications starting, right? So they precede the onset of microvascular complications, right? That is an important thing to note, right? Right. Now, this MCQ, I will talk about these complications a little bit more with question number 8 as well, right? So here we say regarding complications of diabetes, diabetic retinopathy is characterized by microaneurysms and dot and blot hemorrhages. So diabetic retinopathy, right? Now we usually say that the onset of complications in type 1 diabetes, microvascular ones, we usually take about 5 to 7 years from onset, right? 5 to 7 years to get the onset of diabetic microvascular complication in type 1 diabetes, right? And of these, possibly, and this based on large sort of cohort studies, retinopathy tamai chuttak kalin enni. So by the time they have nephropathy, they usually have retinopathy, right? So usually takes about say 5 years. There's a period of 4 to 7 years to develop the microvascular complications. And of the microvascular complications, retinopathy comes before nephropathy. So that is an important point. So established diabetic nephropathy, so 4 to 7 years. So yeah, it is usually within that period that you get it. Take a hurry. Now, and of the 3 microvascular complications, retinopathy usually comes before the nephropathy, right? So make a varadi me thiyana vidiyata. Statement number 3 is wrong. So it is retinopathy preceding nephropathy usually, right? Okay. So this is sort of the onset, the time course of onset of these complications, right? That you need to know. But the problem is in type 2 diabetes, godak velawata, at the time of diagnosis, the disease already started several years ago, right? So you can't go by these times, Harima, right? Because when you diagnose diabetes, type 2 diabetes, they will already have started the disease several years ago. Right? So there are velawal kiyame. Type 1, however, you can follow this timeline reasonably well, right? Hari. Now, when it comes to diabetic neuropathy, this symmetric painful neuropathy is the most common of all the types of neuropathy, right? Other types of neuropathy can be things like mononeuropathy. 6-nerve palsy is a good example of a mononeuropathy, right? And rarely they can get a plexopathy, diabetic plexopathy. Lower limbs are commonly affected there. And autonomic neuropathy is another type of diabetic neuropathy. the commonest thing you see is this symmetrical, painful type neuropathy, right? That is the commonest thing that you see, right? Now, the last statement in this MCQ, again, we have discussed in the long case, right? මම එක පැහැදිලිව කිව්වා that again long trials like and big cohort studies like UKPDS, right? DCCT, right? These are all major diabetes trials have shown that when you control blood sugar, so when you go for a strict glycemic control, it has a very clear impact, right, on the microvascular complications, right? It has a very clear impact on the microvascular complications, but to a lesser extent on the macrovascular complications, right? So that is very important. If you control your blood sugars very well, you will have very good outcome with regard to microvascular complications, but not very clearly with macrovascular complications. The reason there, Lamai, is that macrovascular complications, there are other risk factors for macrovascular complications like hypertension, like hyperlipidemia, smoking, etc. Right? So that is what the evidence shows. UKPDS, DCCT, AK evidence again kiyanne, your control of blood sugar, excellent impact on microvascular complications, but not so much on the macrovascular complications because there are other factors that determine your macrovascular complications. දැන් මෙතන මේ statement එක එච්චර හොඳ නැහැ the way I have worded it, right? But මේක ඉතින් all තමයි ඉතින් tight glycemic control කරොත් macrovascular හොඳ වෙනවා, but not as a greater impact as you see with the microvascular complications. ඒක ලියා ගන්න ඔය MCQ එක එච්චර හොඳ නැහැ ඒ statement එක because yes, if you control the sugars, macrovascular impact එකක් තියෙනවා නැත්තේ නෑ, but it's sort of a very, very strong relationship with microvascular complications. Not so much with macrovascular because there are other factors that are associated. හරි ඒතර ඒකට මම උත්තරයක් කියන්නේ නැහැ, but the point එක තමයි මම අර කිව්ව point එක. Right. Any questions about this question number 8?
So in addition to like reducing the progression, do they also reverse it to some extent?
Reversibility, that's a bit of a controversial area. It reduces the progression and delays the onset. Reversibility in certain situations. Say for example, you have diabetic neuropathy. When you control your blood sugars, that can improve, right? So if for example, if you have a diabetic mononeuropathy or a plexopathy, when you control the blood sugar, it gets better, right? So in certain situations like that, you can argue for reversibility, right? But not for all situations.
So how about nephropathy?
Eka reverse karanna? No. Yeah.
Right, sir. Thank you.
Okay, right. So Kanishka, temporal relationship, neuropathy and retinopathy, not so much, but retinopathy, yeah, so almost always retinopathy precedes nephropathy, right? So it nephropathy, but calling retinopathy, right? But remember that, yeah. So if you have somebody with nephropathy and they don't have significant retinopathy, you have a diabetic who has nephropathy but don't have significant retinopathy, you have to investigate for an alternate cause, right? That's essentially a rule. So type, yeah, yes, Kavinder.
Excuse me, sir. So the thing that you mentioned now, again, even if there's background retinopathy, is that okay, or does it need to be something like pre-proliferative?
Yeah, it has to be proliferative to be the strongest thing is proliferative retinopathy, right? Background, you will have a second sort of think about it, or non-proliferative, but proliferative is the strongest relationship. Yeah. So if they have proliferative nephropathy, you can be 100% sure it is diabetic nephropathy. Yeah, it's very, very strong. But non-proliferative, still there can be a possibility it's non-diabetic.
Right, sir. Thank you.
Now, Gaini, as I mentioned, the timeline of events in type 2 diabetes is difficult to say, right? So nephropathy will occur about say 7 years or 6-7 years from the onset of type 2. But remember, at the diagnosis, when you diagnose it, the disease has already been going on for several years. So you can't go by the timelines in type 2 diabetes, right? Well, disease has been there for several years when you diagnose it. So you can't go by the timeline. Well, පටන් ගත්ත දවසක් කියන්න බෑ. ඒකයි. Right. Okay. Right. So that is question number 8, lamai. And these are some of the sort of trials, right? Some of the trials that show effect of glycemic control on microvascular and macrovascular complications. Right. Okay. Right. Now this is a comparison between the two diabetic emergencies. Right? So diabetic ketoacidosis versus hyperglycemic hyposmolar state. So as you know, diabetic ketoacidosis is almost exclusively seen in type 1 diabetics. Right? Almost exclusively. It can occur in a small subset of patients with type 2 as well. Right? Small subset of patients with type 2, those are called ketosis prone type 2 here. There is a small subset of people. Right. So it's almost always in type 1, exception. Right. So diabetic ketoacidosis, the main elements in diabetic ketoacidosis are the metabolic acidosis, which there is an increased anion gap because these ketone bodies are causing an increase in the anion gap, right? So that is true. The other features are with the ketone bodies, the acidosis and the hyperglycemia, right? Now, as we discussed in the long case and during the sort of medical emergency discussion, I told you that in diabetic ketoacidosis, the mainstay of management is fluid replacement. That is a mainstay of the management. You have to resuscitate the patient with fluids. Even before you start insulin, the key thing is that you have to resuscitate the patient with fluid. And usually there is about a 4 to 6 liter fluid deficit in diabetic ketoacidosis, which you would replace then over several hours. Actually, in hyperglycemic hyposmolar state, right, the fluid loss and the fluid deficit is much higher, right? So comparing to diabetic ketoacidosis, the fluid deficit is much higher in patients with hyperglycemic hyposmolar state. It's about 6 to 8 liters, right? So third statement there is wrong. Right. So that is a comparison there. Right. So let's go back to diabetic ketoacidosis. So fluid replacement, to aiming to replace this deficit of 4 to 6 liters is a mainstay of your management. Right. Then the next thing is to start them on a soluble insulin infusion via an infusion pump. Right. Remember, always infusion, infusion pump. We never ever use boluses of insulin. Not recommended. Right. Not recommended. So it always has to be the soluble insulin infusion that we use. Right. So fluid replacement is the first thing that you do. Insulin replacement is the next thing that you do. A word of caution is that it's always very good to have a look at the potassium level before starting insulin. Right. So that is something that I taught you in the appointments. So very good practice. Have a look at the potassium level before starting the insulin. Because if the potassium level is less than 3.5, you need to replace potassium before giving the insulin. Right? Before starting the insulin infusion, we would give some potassium if it's less than 3.5. And the reason all of you know, when you give the insulin, the potassium levels can drop further. That is why. Right. So, yes, so measure the potassium, and as you know, as you go on, you keep on replacing the potassium while the patient is on the insulin. With potassium replace with KCL. Right. So that is how you would manage diabetic ketoacidosis. The acidosis automatically corrects, so you don't need to give any bicarbonate unless the bicarbonate administration is considered if the pH is less than 7. So pH you can consider giving the patient some bicarbonate as an infusion. But otherwise, Do not worry about the bicarbonate at all. Right. Okay. Right. Another important principle in managing DKA is that, remember, when you are giving the soluble insulin, it is a short-acting replacement that you are giving. You should never stop their long-acting insulin, right? That basal cover that we were talking about, you should not stop it. So while you are giving the soluble insulin as an infusion, we will always continue the long-acting insulin should be continued. Because actually, mechanistically, it is the long-acting insulin that switches off the ketone body production. Right? Our long-acting basal එකෙන් තමයි ketone bodies ටික switch off වෙන්නේ. Right? We are controlling the blood sugar with the insulin, the soluble insulin. But it is the long-acting insulin that switches off ketone body production. So the principle is, when you are giving the soluble, you have to always continue the long-acting insulin. Right. Okay. Any questions about that? I'll talk a few words about HHS as well, practical details that we can ask you at the exam.
So this continuing the long-acting insulin is if they are already on long-acting, no?
Yes. In type 1 diabetics, you will either, they will already be on it, or you will start it when they come in with DKA. Yeah.
Yes, sir. But in Sri Lanka, we get a lot of people on mixed start. No?
That is a different story. So mixed start
What's the guide?
Yeah. So what you have to do is, you have to give the soluble infusion and then put them on mixed start after that. So you can't give mixed start because it has already has a soluble insulin. It messes around with the glucose control. Yeah. So that I would recommend you be cautious or stop it and then restart it once everything comes back to normal. Yeah.
Right, sir. And also, sir, do these patients, I mean, ideally have to be managed in ICU?
Not in ICU, preferably the HDU setting is better, right? Where you can do blood gases and sort of electrolytes frequently. Because overage patient ICU in Sri Lanka, because resource limited settings, you can't get all the DK patients into ICU. Ideally, yes. But HDU ekakavat you should manage. Yeah.
Right, sir. Thank you.
Right. Now, I was talking about HHS. HHS they have a higher fluid deficit because they have more osmotic diuresis in HHS, because osmolarity is high and they excreting a lot of glucose through the urine. So they have a higher fluid deficit. And actually, epidemiological, the mortality is higher in HHS, right? For various reasons. Possibly because these patients are elderly patients with type 2 diabetes, like HHS. So one of the contributory factors could be that they're elderly, they have other diseases. Whereas type 1 diabetes who come with DK are younger patients. So the mortality is higher in HHS, right? Now, in HHS, actually, most of the time, fluid therapy itself can correct the biochemical disturbances, and you don't always need to put them on insulin, right? Fluid therapy deepu gamang, most of the things will correct on their own. So in HHS, fluid therapy has a much greater impact when compared to diabetic ketoacidosis. Of course, if the fluid therapy does not correct the glucose levels, then you would put them on a insulin infusion like you would do in diabetic ketoacidosis. Right? And apart from monitoring the glucose drop, you need to also monitor the osmolarity and see if it drops adequately. There are all values for this which you don't need to worry about at the moment. Right? So higher fluid deficit, higher mortality problems. Fluid therapy is very, very important. And then, insulin also later on. Hari. So question 10 is another one of those annoying ones. What are the causes of hypoglycemia, right? So all of these are correct. Hirata's disease is an autoimmune hypoglycemia condition, right? If you don't know what that is. And I've given you a list of causes of hypoglycemia. Right. Okay. Right. So that's about diabetes and hypoglycemia. Right. Now the last endocrine gland that we were interested in is the parathyroid gland, and we are talking about calcium related issues. Now, let's just talk about hypercalcemia, right? Now, in this table, I have given you the list of causes of hypercalcemia, right? This is the list of causes of hypercalcemia. Now, of all the causes, I would say that hyperparathyroidism, right? So, in sepsis, right, you initially get a hyperglycemia and then the adrenals start failing. In severe sepsis, you get adrenal failure. Acute medicine කරනකොට, in very severe sepsis, you get adrenal hypofunction. So they get hypoglycemia after that. So මුලින්ම adrenals are pumping out cortisol to fight the stress and they get burnt out. And in the latter stages of very severe sepsis, they are actually hypoglycemic. Because of adrenal insufficiency. කල මං කිව්වා පොඩ්ඩක් cortisol ටිකකුත් දෙනවා කියලා. Hydrocortisone replacement in patients with severe sepsis in some situations. Right. So we're talking about hypercalcemia, and I told that hyperparathyroidism is an important cause of hypercalcemia. Right. Hyperparathyroidism. Another important cause of hypercalcemia is malignancy. Right. Malignancy. Rarely, hypercalcemia can be due to granulomatous diseases like sarcoidosis and tuberculosis. And you have drug-induced as well. So these are some of the causes of hypercalcemia. Right. Now, when you're investigating a patient with hypercalcemia, right, when you're investigating a patient with hypercalcemia, it's important to split the patient up into elevated PTH and suppressed PTH. So when somebody presents with hypercalcemia, the easy way to think about the causes are to measure the PTH value, right? And there will be patients who have suppressed PTH, right, and elevated PTH, right? And if their PTH is elevated, you are most likely dealing with either primary hyperparathyroidism or this very rare but specific situation of tertiary hyperparathyroidism. මතකද renal කරනකොට ඒක ගැන කතා කරා, where the parathyroid gland is autonomously secreting PTH in patients with renal disease, right? So if they have elevated PTH and hypercalcemia, you are dealing with either primary or tertiary hyperparathyroidism, right? Okay, so let's talk about hyperparathyroidism. Primary hyperparathyroidism. Okay. So regarding primary hyperparathyroidism, most often due to an adenoma of the parathyroid gland. Eka hari. Right? And remember that there is this classical mnemonic of clinical features of primary hyperparathyroidism. Stones, moans and groans that is a typical presentation. Now, the main problem with primary hyperparathyroidism is that it causes bone resorption, right? Bone resorption. And you can see this bone resorption when you do X-rays, right? So what you see in this finger bone X-ray or the hand X-ray this is called subperiosteal resorption. You get this subperiosteal resorption of bone. And in the skull, you get a salt, pepper pot appearance. Salt, pepper pot skull, very fine lytic lesions. Myeloma appearance but you see this very fine sort of lytic lesions all over the skull. Pepper pot skull. So, subperiosteal bone resorption is a classical feature, right? You get this skull, very small lytic lesions in the skull also. And because you have bone resorption, ALP levels are high. Because that indicates bone resorption. ALP levels are high. So biochemically what you would see is hypercalcemia and elevated ALP. X-rays you would see the bone resorption. Right. And because the serum calcium levels are so high, you get elevated urinary calcium excretion as well. Right. Now, this calcium and phosphate go in opposite directions, right? In hyperparathyroidism, right? So the story is they get high calcium and low phosphate. High calcium and low phosphate. That's a typical biochemical pattern that you get. Right. So hyperparathyroidism, adenoma of the parathyroid gland, causes hypercalcemia. High calcium, low phosphate is the typical biochemical picture, right? Elevated neve adu wenama, and they have a high ALP. Right. Okay. Now, how do you manage patients with hyperparathyroidism? You have to do parathyroidectomy. If they are symptomatic, no questions asked, you will do parathyroidectomy. But even if they are asymptomatic, you would still do surgery. It depends on their calcium level. We have details that I got right? So a certain level of calcium, more than that, you would consider surgery, even if they are asymptomatic, right? It would depend on their renal functions, right? And also their bone mineral density. So if they are rapidly developing osteoporosis, right, that is another important indication for parathyroidectomy. So rapid decline in bone mineral density is an indication for parathyroidectomy, right? Similarly, if they have very high calcium levels or their renal functions are getting worse, you would still do parathyroidectomy. If they are symptomatic, say they have fractures and other bone pains and all these problems, renal calculi, all of these patients, you would go for surgical management. Nipuni. Nipuni, you had a question? No? Okay, fine. Hari. Okay. Now, Tisura, yes.
So, what's the basis behind the polyuria?
Polyuria, calcium. Yeah, so there are several mechanisms. It causes hypercalcemia. So calcium is excreted in the urine, right? So it can carry a bit of water with it, but even more, it causes a tubular defect. Hypercalcemia causes a tubular defect, which causes polyuria, right? The water resorption is affected.
Okay, sir. Thank you.
Hari. Now, somebody asked about hungry bone syndrome in one of these sessions that we did. Essentially, what happens is, when there is hyperparathyroidism, there is a lot of bone resorption. Hari. The moment you remove the parathyroid gland, calcium bone the bone suddenly eats up all the calcium that is there. Then it's under the control of the parathyroid gland. When you remove the parathyroid gland, suddenly bone calcium concentrate bone. So they get post-operative hypocalcemia. Right? That's called hungry bone. Now, right? Bone is hungry. It suddenly takes up all the calcium that is given out into the circulation. So that can cause very severe post-operative hypocalcemia, which is called hungry bone syndrome. So hypercalcemia, you are talking about either elevated PTH or suppressed PTH. Elevated PTH, either primary or tertiary hyperparathyroidism. Suppressed PTH, then you consider things like malignancy. You consider things like granulomatous disease, vitamin D intoxication. Right? Well, granulomatous disease, the mechanism is they secrete a vitamin D-like substance. Right? So it is essentially a high vitamin D level. Right. Okay. Right. Now, here word about managing hypercalcemia is another thing that you need to remember. So, hypercalcemia management, the key thing is fluid resuscitation. So, they can get significantly dehydrated. So, you need to give fluids. Right? Fluids is a very, very important part of the management. The next thing that you have to do is we usually give intravenous bisphosphonates for these patients. Intravenous bisphosphonates, right? That is a treatment. Pamindronate is a commonly used drug. some conditions like malignancy-related hypercalcemia or granulomatous disease hypercalcemia respond to steroids, right? So it is fluid therapy and IV bisphosphonates and also steroids for some etiologies, not everybody, some etiologies like granulomatous disease-related hypercalcemia or malignancy-related hypercalcemia may respond to steroids. So dexamethasone intravenously is another thing that we use. Right. Any questions? Right. Now the reverse of hyperparathyroidism is hypoparathyroidism. Right. Hypoparathyroidism can cause hypocalcemia. Right. And prostexine, trusosine. Hold on. That there's a question. CKD who has tertiary hypertension upon kidney transplant, can it cause phosphate levels to reduce? So in tertiary hyperparathyroidism, the calcium levels are high and the phosphate levels are low usually. That's so when you have hyperparathyroidism, the phosphate levels are low. Anyway. Okay, right. So hypoparathyroidism, prostexine, trusosine, you've heard of this in surgery. That's a very common sign to look for. Hypocalcemia causes long QT, not short QT, right? Short QT. Right. And all of you have heard of this pseudo-hypoparathyroidism, neither? Two classical features of pseudo-hypoparathyroidism are MEVA, right? Short fourth metacarpal, basal ganglia calcifications, වගේ දේවල් you will get in pseudo-hypoparathyroidism. මේක recognized feature of pseudo-hypoparathyroidism කියලා හදාගන්න මේක fourth MCQ එක. So short fourth and fifth metacarpals are not in primary hypoparathyroidism, it is in pseudo-hypoparathyroidism. So pseudo-hypoparathyroidism when there is a receptor level defect to PTH. That is what happens, right? It is not a gland problem, it is a receptor level problem. Right. Antime kapagan එක උගලන්ට වැඩි, right? That's not important. Right, so a little bit, කලාතුරකින් අහන්නේ hypoparathyroidism is a very rare thing. We don't usually talk about it in medicine. Surgery වල ඉතින් thyroid surgery වලට secondary. But hypercalcemia, they can ask about PTH, කතන්දර ටිකක් චුට්ටක් අහන්න පුළුවන් in that setting. Okay. Any questions about that? Right. Now, what we'll do is we'll finish off the best response MCQs. There are 5. And then go back to the පළවෙනි paper එකෙත් කීපයක් තිබුණා to do. Right. So this is a patient who has chronic kidney disease, right? And in the data, the PTH level is high, right? Low calcium, high phosphate. Neither. So what is the thing there? This is very familiar to us. Neither. So low calcium, high phosphate with a high PTH. This is secondary hyperparathyroidism. This is a common thing that you see in patients with renal disease, where they have a problem in secreting the phosphate, right? Because that's actively secreted. The phosphate goes up because they have a problem in doing that. Because of the lower levels of active vitamin D, their calcium levels are lower as well. Calcium එකත් බහිනවා. So they have a low calcium and a high phosphate, and this triggers off a high PTH level. So they have high PTH levels. So this is secondary hyperparathyroidism. In tertiary hyperparathyroidism, right? ඔක ස්ථානිකර reverse වෙනවා. හරි? Calcium level එක වැඩි වෙනවා, phosphate level එක අඩු වෙනවා, and the PTH is very, very high. Very, very, very high. Right? Because autonomous secretion of PTH. Right. හරි. So මෙතන ලොකු කතාවක් දීලා තිනවා MI එකක් තියෙනවලු current medication ගැන කියලා තියෙනවා. Right. Now this මම ඇත්තට මේ ප්‍රශ්නේ හැදුවේ ටිකක් ඉස්සර. So yeah. Based on current evidence, what is the best drug to give here? So a patient has poor glycemic control, has acute myocardial infarction, heart failure තියෙනවා, right? Based on current guidelines, what is the best drug to give here? Next. Or what is the change that you would do here? කියන්නනේ ඔයගොල්ලෝ කටහඬවල අහන්නත් ආසයිනේ.
So is it to add the glycoside, the sulfonylurea?
Sulfonylurea, isn't there a better thing to do here? Sulfonylurea එකක් දෙනවට වැඩිය මෙතන.
Or insulin?
Okay. Now say you have all the right. So here in Sri Lanka, what you would do is stop the pioglitazone. You're right. Can you give the pioglitazone? No, because of the heart failure. හරිද ඉස්සර? So substituting the gliclazide into the pioglitazone would be the best thing to do. If that doesn't work, then insulin. Hari, you're right. But I said, based on current guidelines, what is the best thing to do here? If you have everything available for you, then if I were you, I would start at SGLT2 inhibitor.
SGLT2,
Yeah. So if you have all the facilities available, all the drugs available, then you would start SGLT2. There are lots of benefits of SGLT2. So stop the pioglitazone, but then that's not good for heart failure. We would give him the SGLT2 inhibitor because that has a cardiovascular mortality benefit. He has MI at a young age. So that would give him that cardiovascular protection and is good for heart failure as well, right? So that would be the best here thing available. And when they give you a best response MCQ, go for the guideline recommended thing. ලංකාවේ මේක නෑ අරක නෑ කියලා කියන්න එපා. Go for the guideline thing. මේක මම ඉස්සර හදපු එකක් නිසා මෙතන the SGLT2 is not an option in this MCQ, right? හැබැයි මෙතන SGLT2 එකකුත් තිබුණා නම් එහෙම that would be the better answer rather than putting the gliclazide in. හරිද ඉස්සර?
Right. And how about the insulin regime?
That's fine.
Option?
Insulin is also an option. Yes. But you have to stop the pioglitazone. That is important. Right?
All right. Okay.
Heart failure එකක් තියෙන නිසා චුට්ට. Okay, good. Right. Then this one is a calcium related thing, right? So hypocalcemia, high phosphate and symptoms of hypocalcemia. So what would you do now? So low calcium, high phosphate, remember they go in the different directions in parathyroid related issues. So here we are most likely dealing with primary hypoparathyroidism. I would start off by doing a parathyroid concentration, right? And then taking it from there, right? If it was a vitamin D deficiency causing hypocalcemia, what would happen? So the two things to remember are, in hypocalcemia, if your calcium is low and the phosphate is high, that is always parathyroid. Alright? If the calcium and phosphate both are low in a patient with hypocalcemia, that is vitamin D deficiency, severe vitamin D deficiency. Alright? ඒක මතක තියාගත්තා නම් ඇති. So here you can see the calcium is low, phosphate is high, and the patient is hypocalcemic clinically. That is PT. So I would start by doing a PTH concentration here. Right. Okay. Question number 4. Yes. Question number 4. 4 wala. So there is a story about somebody with diabetes with proteinuria. HbA1c is high. The patient has 1.5 grams of protein. Right. So what is the best thing to do here to prevent the progression into renal failure? මෙතන මොකක්ද අපි කරන්න ඕනේ in this situation? ළමයි?
Improve glycemic controls.
Yeah, so improved glycemic control would be the most reasonable thing to do. ACE inhibitors උනත් කමක් නැහැ, but improving glycemic control would be the best thing to do. Yes. හරි.
So how do you decide between the two, the ACE inhibitor and the glycemic inhibitor?
ඒ දෙකම හොඳයි. It's a bit of a controversy නෙමෙයි. ওই දෙකම එක වගේම හොඳයි. ඉතින් if you would ask this question in a paper, we would give answers for both most of the time. Yeah. But yeah, it's not a big problem.
Yeah.
Hari? Don't make it a big issue there. Right. Now there are few more MCQs in the other one. නේද? දැන් එක හොයාගන්න ඉස්සෙල්ලා. අපි එක කරේ නෑනේ. Endocrinology. Here. Right. So there were a few questions in this one. Yes. First to do. Right. Now in the first question, the focus is on hyponatremia. නේද? හරි නේද? So there is a question from Kusala, are there any hypoglycemic called liver disease? Sulfonylureas වගේව liver disease වල දෙන්නේ නැහැ. Metformin also you are a bit cautious about it, especially if the patient is decompensated. Right. Okay. Now, right. So the first question is focusing on hyponatremia. Now, mama samahara groups වලට මේක ඉගෙනුවා, but I will මට මතකයි හැමෝටම කරාද කියලා hyponatremia. So essentially, when you have a patient with hyponatremia, the first thing to do is classify them into one of three groups. Right? මුලින්ම තුනකට බෙදනවා. Right. So what are the three groups? Right. The three groups are, number one, patients with hyponatremia who are hypovolemic. So hypovolemic hyponatremia. Right. So patients who have, say, diarrhea, vomiting, and lose sodium, right, they can end up with hypovolemic hyponatremia. That is group number one. Right. Group number two is some people have fluid overload which dilutes the sodium concentration. Right. So fluid overload dilutes the sodium concentration. That is hypervolemic hyponatremia. Right. So you see this in patients with heart failure or renal failure, fluid overload, which dilutes the sodium concentration. Right. So that's hypervolemic hyponatremia. Then finally, you have a group of people who are euvolemic. No change in their volume status. They have euvolemic hyponatremia. Right. Euvolemic hyponatremia. And SIADH, syndrome of inappropriate ADH secretion, results in euvolemic hyponatremia. Euvolemic hyponatremia. There are two other important causes of euvolemic hyponatremia, and they are cortisol deficiency, that is Addison's disease, or hypothyroidism. So SIADH is one, right? Then the next one is cortisol deficiency and also hypothyroidism. They can give rise to a very similar picture. Right. Now, මෙතන volume status එක ගැන ලොකුවට කියලා නෑ, right? But looking at the investigations, right? Let's see what we get from that. So the sodium is low, the plasma osmolality is low, and the urine osmolality, even though it's normal, is high for a sodium of 128. So the cutoff, මෙතන බොරුවට දීලා තිබ්බ 350 1000 කියලා, it's actually 100. In the setting of hyponatremia, the urine osmolality cutoff is 100. So it's more than 100, that is high. Right? This is biochemically suggestive of an SIADH type picture. Right? So low serum sodium, reduced plasma osmolarity and increased urine osmolarity. And if you measure the urine sodium, that will be more than 20 as well in these people, right? More than 20. So this is a SIADH like picture, right? And of these things, fluoxetine is well known to cause a SIADH like picture, right? These are SSRIs, which are well known to cause a SIADH like picture. Lithium causes the other side, right? It causes diabetes insipidus, right? Lithium. Ekat ahanna puluwan MCQ වලට අහන්න පුළුවන් දෙයක්. Right. So that's a very simplified approach to a hyponatremic patient, right? Any questions?
So, in diabetes insipidus, what is the urine osmolarity cutoff?
Diabetes insipidus, urine osmolarity cutoff එක they give the reference range. ඒක එහෙම එක විශේෂකම් නැහැ. Yeah. This is, yeah, they will give the reference range for that.
Thank you.
Metan reference range එක දුන්නත් anything more than 100 is high, right? That is the trick there. Right. Okay. Question number 2 focuses on a patient with hyperthyroidism, right? And in pregnancy. So clinically hyperthyroid, the TSH is suppressed and the T4 is elevated, right? So what would you do in this patient? මොකද්ද මෙයාට දෙන්නේ? Yeah, so you start off with propranolol. Even if you have said carbimazole, I wouldn't mark you wrong. So මේවයි ගොඩක් වෙලාවට වෙනවා සමහරට අපි උත්තර දෙකකට ලකුණු දෙනවා. දැන් මෙතන මම අහලා නැහනේ මොකද්ද ඉස්සෙල්ලා දෙන කතන්දරයක් කියලා අහලා නැහනේ. So even if you said carbimazole or propranolol, I would still give you marks. The problem with carbimazole is it can rarely cause fetal problems, very rarely cause fetal problems, as I think we discussed before. Of the two antithyroid drugs, propylthiouracil is safer in pregnancy, right, of the two. Right. And of course, you can't give radioactive iodine in pregnancy. That is obviously nonsense. Right. Lithium is also good at lowering thyroid hormone levels, but again, you can't give it in pregnancy because of the risk of fetal problems. Right. Okay. Good. This is easy, right? Acromegaly. And we talked about the screening test for acromegaly being IGF-1. Right. And then you would try to challenge the growth hormone by giving a suppressive test like OGTT as the confirmatory. Right. Sorry. Last one. No, sorry. So, blah, 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 diabetes, poor control, blood pressure, poor control, and abdominal striae, bruising, proximal myopathy, very nice story of Cushing's here. So, I told you that for Cushing's, the first thing you need to do is screening tests, right? You need to do screening tests. And for that, you have the option of either doing a 24-hour urinary free cortisol, a midnight salivary cortisol, or overnight dexamethasone suppression test. Once you have screened the patient, then you do a low dose dexamethasone suppression test as for confirmation, and then do a ACTH level. ACTH level is to say, is this ACTH dependent Cushing's or is this ACTH independent Cushing's? That is the intention of doing an ACTH level, right? So here the answer is urinary free cortisol, but then next you do the low dose dexamethasone and then the ACTH level, right? And then you would consider doing the high dose dexamethasone if it's a ACTH dependent cause, because we talked about this last time about the ectopic and pituitary and how they behave with the high dose dexamethasone suppression, right? Okay. So this question is a patient with hypertension, right, and low potassium and a metabolic alkalosis. Sounds familiar, neither? And we know that this is a hyperaldosteronism state, where the hyperaldosteronism pushes out the potassium, pushes out hydrogen ion, giving rise to a metabolic alkalosis. Right? So here also, even if you said adrenal adenoma or adrenal hyperplasia, I would accept the answers because it's impossible to say biochemically whether it's adrenal adenoma or adrenal hyperplasia, right? Yeah, so I would accept any of those answers. Hari.
So, so the last question, sir, in a setting of ectopic ACTH secretion also, sir, wouldn't you get the same picture?
Yeah, but then they have to give saying that the patient has pigmentation or something else, right? Just by this, it's more suggestive of hyperaldosteronism rather than ectopic. But you can get a very similar biochemical profile in ectopic ACTH as well. But the story there is going to be different. The leading up to the question is going to be different. The history is going to be different.
Thank you.
Right, so that is endocrinology done. Any questions? So hyperaldosteronism, does it cause fluid retention? Not really, right? It doesn't. So in primary hyperparathyroidism, high calcium, low phosphate, right? Okay. Tertiary also similar, but the calcium levels are going to be very, very high, right? Phosphate levels are going to be suppressed. There is no control. Secondary, I think obviously it's a trigger. Low calcium, high phosphate causes secondary hyperparathyroidism. Secondary hyperparathyroidism doesn't cause hypercalcemia, right? It's the low calcium, high phosphate that triggers it off. So if somebody presents with addisons and shock, first step is to give fluid. Yeah. If somebody, what is the next step to do? Fluid, not hydrocortisone. The first thing you do is fluid, then hydrocortisone. Hari. Okay. චමත්ත නියුරොලොජි ටික මම දැම්මා. ඒකේ මෙහෙමයි හරිද? ඒකේ දැන් ක්වෙස්චන් පේපර්ස් දෙකක ප්‍රශ්න තියෙනවා. තව අර මේ ප්‍රසන්ටේෂන් එකෙත් MCQ තියෙනවා. හරිද? ඒ ටික ඔක්කොම කරන්න.
හරි සර්.
හරි. අර ඉතුරු දෙකේ ප්‍රසන්ටේෂන් දෙකක් තියෙනවා. ඒක මම දාන්න දැම්ම දාලා දැන් ඒක උත්තර තියෙනවා. මේ ඒක කරන දවසට කලින් දවස් දාන්න. හරිද? right. ඒතර ඒක කරා මේක ඩබල් සතිය මොකද?
අනේ සර් GIT මේ නෝට් එක
එකක් දාන්න. හරි. මේ අනිත් එක තමයි ඒතකොට දැන් නියුරෝ කරාම ගොඩක් ලොකු ඒවා ටික ඉවරයි. ඊට පස්සේ රුමටොලොජි, හිමටොලොජි වගේ පොඩි පොඩි ඒවා ටිකක් තියෙනවා. ඒ ටික ටක් ගාලා කරලා දාන්න පුළුවන්. ඒතකොට ලබන සතිය අග වෙනකොට ඉවර කරන්න පුළුවන්.
හරි.
හරි. ඔව්. ඉන්ෆෙක්ෂස් ඩිසීස් වලත් චුට්ටක් තියෙනවා දැන් ඔය කවර් වෙන්නේ නැති ඉන්ෆෙක්ෂස් ඩිසීස් ටිකක් තියෙනවා. ඒකත් ලොකු සීන් නෑ එතන. හරි.